Very warm welcome to all of you, to the members of the press, and also to our distinguished panels of speakers today, experts, researchers, and representatives of EULAR. EULAR is the European Alliance of Associations for Rheumatology, and it represents 3 pillars. The first pillar, most and foremost, is the patients, the people affected by rheumatic and musculoskeletal diseases, or as we also refer to, RMDs. Secondly, EULAR also represents health professionals in rheumatology. And thirdly, EULAR unites the scientific societies of rheumatology across Europe. This year, we are celebrating the 22nd EULAR Congress, and it's the 2nd year in a row, for obvious reasons, that we hold this conference in the virtual space. But nevertheless, virtual or physical, the Congress is and always has been the primary platform for scientific and clinical information in the field of rheumatology, and it is the forum for scientists, for medical doctors, for people with RMDs, for health professionals, and also representatives of the pharmaceutical industry to get together and come together. And yeah, as I said, as every year in the Congress, we celebrate excellence and achievements in the field of rheumatology. And so today in our press conference, we would like to share with you some of the outstanding findings of this year's Congress. So I'm very happy to share with you our distinguished panel of speakers. If we can see the program and the agenda now, you see we have 6 speakers here with us today. I will quickly introduce each of them and then give the floor to them to speak about their studies, about their projects. So let's start. And I'm very happy to introduce to you our first speaker, Professor Iain McInnes. Iain is a professor of rheumatology at the University of Glasgow in the UK, where he's also the vice principal and head of college. And of course, he's also the EULAR president. And so I'm very honored to have him here today and to hear about the new EULAR Research Centre. Please, Iain, the floor is yours.
Thank you very much indeed, Carina. Thank you for introducing us so eloquently and beautifully. Well, greetings to all of you, wherever and whenever you happen to be joining us. It's an absolute pleasure for us to welcome you to this, the 2021 Congress. It's going to be a festival of clinical and medical science. It's going to be a gathering of the wisest minds in our discipline across the world. And of course, whilst we wish we were gathering physically in proximity, we are also very happy to be able to join you in the virtual world. And thank you, therefore, for your interest in our Congress and this press conference at the moment. Well, I want to tell you about the new EULAR Research Centre. Never more than now do we understand how vital medical research is for the future of humanity. If you think about the extraordinary advances that we have made in the last 12 months in understanding a new disease caused by SARS-CoV-2, then, well, you can imagine what an extraordinarily exciting time it is when we see the full force of molecular science applied to clinical challenge, to the benefit of society. And you'll hear from Pedro in a few moments how EULAR has responded in many ways to the COVID crisis. But medical research underpins our future. And we in EULAR have committed ourselves to building a future capability, capacity, if you like, to deliver high quality research right across the range of disciplines to help people with rheumatic and musculoskeletal diseases. And so we have launched the EULAR Research Centre. It is an organisation that is growing. The Research Centre is offering, first and foremost, consultation services available to investigators throughout the EULAR participant countries and indeed beyond. And the idea is that investigators with a great idea, a really important question, will approach the research centre with that question, and we will match them with world-class expertise to drive forward that project with them, to make sure that trial design, delivery of trials, management of statistics, ethical issues, application issues, and even management of funding issues are all managed at the highest level of quality. And with that, the quality of the research output, if you like, the answers that are so important for people with rheumatic and musculoskeletal diseases will be delivered as quickly as possible, but with the highest quality to ensure that the data that are produced are robust and can be implemented to improve quality of life. So the EULAR Research Centre, since its launch, has in fact now offered consultation in the order of 11 times. We've had many more applications than that, but we do have some criteria that set out what are those projects that are most eligible. I'm very pleased to say that those 11 projects that we are currently supporting come from 9 different European countries. So there's some diversity already. And I can also tell you that those who are making use of this service provided by the EULAR Research Centre are exhibiting a broad range of backgrounds and expertises. We have connections now with everyone from PhD students all the way through to professors, and countries from as far apart as Russia, Netherlands, and southern countries within the European continent. And so broad representation already, and a very exciting time for us in the Research Centre as we see it growing in front of us. Of course, our ambitions go well beyond this. We are supporting already clinical and translational science. We are looking to build initiatives in the area of public health and epidemiology in the coming months. We also work with the EULAR School to provide additional opportunities to train, to provide expertise, underlying support, for example, in research methods, in digital healthcare and data science, with a focus mainly on rheumatic and musculoskeletal diseases, of course, but ensuring that we equip investigators, researchers with those core skills that are necessary to perform high quality research in the 21st century. We also are working together with some of the high quality researchers already working across Europe to bring them together to make them highly competitive in the forthcoming Horizon Europe competitions. We know that there will be funding made available, particularly through the European Union, to support medical and biomedical research. We want the rheumatic and musculoskeletal diseases to be at the very forefront in those competitions. And so the EULAR Research Centre is supporting those integrative ambitions. And finally, in due course, it's likely that we will be offering other opportunities together with our sister foundation, Forum. Forum is the major funding agency that offers support in rheumatic and musculoskeletal diseases research across the EU and other affiliated EULAR countries. It's a foundation that is closely related to EULAR and will work very closely with the EULAR Research Centre to support the development of capacity and the delivery of extraordinary research. And we'll look forward to announcing new initiatives in the coming months that will empower investigators to change lives. Thank you very much indeed for joining us. I'd be very happy indeed to take any questions that you have.
Great. Thank you so much, Ian. It sounds very interesting. Do we have any questions from the members of the press? Please don't be shy. You can just write them in the chat. There is one question. Ian, do you have any plans to develop this research centre further and to also help researchers find collaborators, both academic or also in industry?
Yeah, that's an excellent question. Thank you very much indeed for posing it. And the answer is we absolutely do. I touched already on the initiatives around Horizon Europe, and so we do indeed plan to bring experts together to put them into platforms which we believe will be as highly competitive as possible. Now, of course, it's not that this is the exclusive route into Horizon Europe, quite the contrary, but we do believe that the EULAR Research Centre is an excellent vehicle to bring investigators together. Now, our primary objective in our first phase is to bring academicians together, but in due course, we will be reaching out to form integrated links with our friends and colleagues in the industrial sector. The future of biomedical science will comprise collaboration between academic investigators, healthcare systems, governments and health payers, and of course, mainly the pharmaceutical and biodevice industry. It is that coming together, that partnership, which really empowers rapid progress. Again, I would make reference to what we have seen in the COVID era with industry, pharma, academia, healthcare systems working seamlessly to make extraordinary progress. We envisage something very similar going forward to make those incredible advances that are so important, so essential, so necessary for people with rheumatic and musculoskeletal diseases.
One more question for you, Ian. What about researchers outside the EULAR region? Does EULAR also offer anything to them?
At the moment, our primary focus is within the EULAR region. We are, however, offering project support to investigators who come to us from Africa. And this is a particularly important project for us. We're working in partnership with the African League of Associations of Rheumatology, AFLAR, and we're doing this because there is such exquisite unmet need. There are almost no rheumatology services in many countries in the African continent, and we felt that that was an area in which we should make particular focused investment. And so going forward, we are intending to support a number of projects in that region. Going forward, as our research centre matures, as we really find our momentum, as we find our gravitas, it is our ambition to work with other partners around the world. Rheumatology is an inherently collaborative discipline. We actually already work together with our friends in North America, South America, with our friends in Asia, and of course, I've mentioned already partnerships forming in the African region. And in the longer term, the EULAR Research Centre, I hope, will be one of the major catalysts to the delivery of high quality research on the global stage. Great question. Thank you very much.
Wonderful. Thank you very much, Ian. To the members of the press, if you have any additional questions to Ian afterwards, please address them to us, press@eular.org. And then we will move on in our program to our next speaker. Thanks again, Ian. Professor Pedro Machado. Pedro is Associate Professor at the University College London, and he's also member of the EULAR Executive Committee and the COVID-19 Task Force. And today he's going to talk about the first lessons learned from the pandemic and the EULAR COVID-19 and COVAX registries. Pedro, please.
Thank you, Carina, and it's a pleasure to be here today on behalf of EULAR. As you all know, the global COVID-19 pandemic has presented a huge global healthcare challenge, and rheumatology is not an exception. And many patients with rheumatic diseases, they have an underlying immune dysfunction, or they're treated with drugs that affect the immune system. These are called immunosuppressive or immune modulatory drugs. Moreover, they can also experience higher levels of comorbidity. And this raises questions and concerns about the impact of rheumatic diseases and their treatments on the outcomes of SARS-CoV-2 infection. However, these concerns also provided the encouragement to create a wide-ranging global research collaboration to address these urgent issues. And this is what led to a partnership between EULAR and the Global Rheumatology Alliance to collect as much data as possible from patients with rheumatic diseases and COVID-19, with data being entered voluntarily and directly into either a global or European data entry system or transferred from national registries, like is happening with France, Germany, Italy, Portugal, Sweden, and Switzerland. And this is being done all under the umbrella of EULAR. And ultimately, the purpose, the objective of this collaborative effort is to collect, analyze, and disseminate information about COVID-19 and rheumatology, and to improve the care of patients with rheumatic diseases. Now, we recently published data from almost 4,000 people with rheumatic diseases and COVID-19. And we looked to see if there were any common factors in the people that died compared to those that recovered from the COVID-19 infection. And what we found was that an older age and male sex was associated with COVID-19 related death. So for example, of those who died, over 2/3 were over the age of 65. The risk of dying was even higher in people over the age of 75, and for men, and higher for men compared to women. Now, we also found that comorbidities, so concomitant diseases, were also more common in people that died from COVID-19. And across the group of subjects that was included, most people had at least one other disease or comorbidity, the most common being hypertension, chronic lung disease, and obesity. Now, in the whole group, 21% of people had 3 or more comorbidities. So these comorbidities were independently associated with the higher likelihood of dying from COVID-19. We also found that certain medications were associated with COVID-19 related death. So people taking rituximab, which is a specific drug that depletes a specific type of cell in our body, B cells, and also sulfasalazine, and also higher doses of steroids. Those subjects were also more likely to have a more severe outcome of COVID-19. And another important finding, and I think probably the most important finding, was that people with high disease activity, so those subjects where the disease remained active or uncontrolled, they were more likely to die from COVID-19 compared to those where the disease activity was low or in remission, where the disease was inactive. So I think in summary, this work highlights that the risk of dying from COVID-19 varies according to the people's underlying disease activity and what medicine they're taking. Most of the factors associated with the worst outcome are the same as described in the general population, specifically age, male gender, and the presence of other comorbidities. And I think it is really important that the data is showing that for people with a rheumatic disease control should be the priority with what we call disease-modifying anti-rheumatic drugs, so the immune modulators and the immunosuppressants that often these patients have to take in order to control the disease. And the other aspect I would like to talk about today is the EULAR COVAX registry. Now, the EULAR COVAX registry was created to inform about the safety of COVID-19 vaccination in patients with rheumatic diseases. It is also a physician-reported survey, similarly to the COVID-19 registry, and cases of patients with rheumatic diseases that have been vaccinated with any of the COVID-19 vaccines, with or adverse events, including flares. These cases are uploaded by colleagues and other healthcare professionals into this registry. And, throughout history, vaccines have contributed in a major way to protecting the health and the safety of the worldwide population. And the speedy development of several vaccines against COVID-19 and the huge efforts currently ongoing to vaccinate the global population, they brought a lot of hope that the COVID-19 pandemic will start to subside, and we're starting to see that effectively. Now, but with new vaccinations, there were also concerns that arise with regards to their safety, particularly with people with inflammatory or immune-mediated conditions, like those that affect patients with rheumatic diseases. And again, also because often these people are treated with drugs that affect their immune system. So this is what prompted EULAR to set up a dedicated COVID-19 vaccination registry, the COVAX registry. And the first findings of this registry will be presented at EULAR in a late-breaking abstract session. Now, as of 21st of May, more than 2,500 cases from more than 30 countries had been reported to the COVAX registry. Now, at EULAR, in the late-breaking abstract, we'll present the data from the first 1,519 patients. And what the data is showing is that the safety profiles of the COVID-19 vaccines in patients with rheumatic disease is very reassuring. Most of the adverse events that were described are exactly the same as those in the general population, so namely short-term and non-serious symptoms like fatigue, headaches, flu-like symptoms, myalgia, and the overwhelming majority of patients tolerated their vaccines very well, with rare reports of an inflammatory rheumatic disease flare and very rare reports of severe adverse events. So these initial findings should provide reassurance to rheumatologists and to vaccine recipients, and should promote confidence in COVID-19 vaccine safety in patients with rheumatic diseases. And to conclude, I think these registries demonstrated the strength of EULAR in fostering collaborations across Europe and beyond, and EULAR looks forward to strengthening these networks and pipelines further.
Thank you very much, Pedro. We have time for one question, and there's already one. Can you please elaborate, according to the data you already collected, are the COVID-19 vaccines safe for people with RMDs?
Well, very safe according to the preliminary data that we've collected. The data is really reassuring. As I said before, most of the potential adverse events being picked up so far are very common adverse events observed not only with COVID-19 vaccines, but with all types of vaccines. So local reactions such as pain or more systemic flu-like symptoms such as fatigue and headache. There are a few reports of flare of the rheumatic disease that have been described, but these tend to be mild, and only among those 1,500 cases, only 2 cases of serious adverse events were reported. So with vaccines now given to more than 1 billion people worldwide, I think patients with rheumatic disease are not the exception, and the data is showing that all the vaccines seem to be quite safe in our patients. Vaccines have been one of the greatest medical advances of modern times, and the data in the general population, but also in patients with rheumatic diseases with regards to COVID-19 vaccines is also showing the same.
That's very reassuring. Thank you very much, Pedro. We will then move forward to our next speaker today. This is Professor Dr. Thea Vlieland. Thea is professor at the Department of Orthopedics, Rehabilitation and Physical Therapy at the Leiden University Medical Center in the Netherlands, and she is also vice president of the EULAR Health Professionals in Rheumatology, or HPRs as we also refer to them. Thea, you will talk today about a study on remote care for people with RMDs. So the floor is yours. Thank you.
Thank you, Carina. And previous speakers already addressed the impact of the COVID-19 pandemic, and this has, of course, also a large influence on the process of delivery of care to people with RMDs. Regarding the provision of care, various forms of remote care were already available before the pandemic, but remote care was more rapidly and on a much larger scale implemented over the past year. Of course, this brings along many questions on its effectiveness and safety and also its accessibility. So it's not surprising that remote care will be extensively addressed during this EULAR's annual Congress. And as an example, I would like to highlight an abstract from Dr. Ndosi and colleagues. And Dr. Ndosi is a nurse and senior lecturer in rheumatology nursing in Bristol, UK. Dr. Ndosi and colleagues studied to what extent remote review of patient records would be useful to inform treatment decisions on medication. The study included patients with rheumatoid arthritis who started a new biologic medication therapy. In their study, a nurse and physician at the outpatient clinic had access to the same information, and this information included the medical history, the patient's self-assessments of pain, fatigue, disease activity, reactions to drug treatment, disability, and self-efficacy. The nurse only had this information and studied it remotely without seeing the patient. And the physician actually saw the patient at the outpatient clinic within 2 weeks, and at this visit also had access to the blood test results and the joint count. In total, 57 matched decisions were studied, and there was only one adverse event that needed stopping treatment, and that was identified both by the remote review and by the actual outpatient visit. And the authors concluded that there was a fair agreement between the remote decisions and the outpatient clinic decisions for drug treatment. But overall, the author thought that knowing the blood results would have significantly improved the remote decision. Now, what does this study teach us? Of course, it does not imply that outpatient clinic visits will not be needed anymore in the future, but it demonstrates how clinicians and patients can make alternative use of information that patients are often already providing. They are often routinely completing questionnaires in daily practice. And by carefully examining the results, the need for a visit to the outpatient clinic can be better planned. And this is, of course, relevant both for patients and clinicians. And the study also highlights how health professionals can have an important role in this remote review. Now, this study was mainly on the medication side, but health professionals can, of course, support patients in managing their condition in many more aspects of their lives. This is a key role for health professionals, and this can also be provided in a remote way. This year's Congress has many more examples of evaluations of remote care, and I would like in particular to promote a debate held on this theme on Saturday, June, 9 hours, June 5. And here the pros and cons of remote rheumatology will be discussed by patients, rheumatologists, and health professionals. And of course, there will be input from the audience. Thank you, and I'm happy to take any questions.
Thank you very much, Thea. Do we have any questions from the audience? Thea, can you elaborate again? You already mentioned it. What is the role of health professionals in remote care for people with RMDs? Can you give a few examples?
Yes, of course. As I already said, there are many forms of care they can deliver. During the COVID pandemic, health professionals served in many practices as a first point of contact for patients with any questions about their medication provision and also prescriptions and also vaccinations. And also they can give support to patients who had difficulty in, for example, doing their exercises or had more mental problems with coping with the pandemic. And here health professionals can support patients with giving education and also practical support referring patients to health professionals, for example, in primary care, or different forms of education and information that are available, for example, on the internet.
Thank you very much. And when we're talking about remote care, can you talk again about the role of remote care for people with RMDs after the pandemic? COVID-19 pandemic.
Yes, of course,
the role of remote care for
we are
people
all
with RMDs after the
the
COVID-19.
real personal physical contact a lot. But I think the rapid implementation of remote care during the pandemic has also showed us that there are opportunities. I think there are opportunities for a better preparation of consultations by patients and healthcare providers. And it also has certain practical advantages, no travel, which can be favorable in certain circumstances. For some people, the barrier to contact a health professional may even be lower than with regular care, because an email or a telephone contact is probably more easily. So maybe in the future, the beneficial aspects of remote care can be better used and on a larger scale.
If there are no more questions for Thea, then I thank you very much, and we look forward to the sessions at the Congress. And then we will move forward to our next speaker today, which is Professor Loreto Carmona. Loreto is a rheuma epidemiologist and a scientific director of the Institute for Musculoskeletal Health in Madrid, Spain. And at EULAR, she is the chair of the advocacy committee, as well as the program chair of this year's Congress. Today, Loreto will talk about different studies about lifestyle-related topics of people with RMDs. Thank you, Loreto. The floor is yours.
Thank you, Carina, and thank you, everybody, for being here today for this press conference. I am delighted to show you that rheumatology also has a room for prevention. So we have selected 3 abstracts from the full list of abstracts from the Congress, the 3 of which have a relation to lifestyle. The first one is abstract 3758, which is about the gene-diet interaction in the risk of incident gout in women, and we will talk a little bit about it later on. Then the second abstract is abstract 1260 on the association between passive smoking in childhood and adulthood and rheumatoid arthritis, and this is from a very large cohort study in France. And then the third one is abstract 3863 on air pollution and the response to biologics in chronic inflammatory arthritis. So the topic today is about diet, smoking, and pollution. And all of us know something about these things, right? So that's what brings this topic so close to us. Listen, the first thing a patient asks when she is diagnosed with an RMD or with any chronic disease is, what can I do for myself? And one of the things this patient can do for herself is actually modify her lifestyle, if there is something to modify in there. The problem here is that most medical doctors, and rheumatologists are among them, do not know much about how to modify a diet. We have some concepts that we know from the cardio-healthy lifestyles, but we don't know much about how to modify a diet for a rheumatic disease, or else we do not know much about other preventive actions, right? Perhaps all the things that we can recommend patients is to live a healthy lifestyle. This healthy lifestyle, if you think about it, which was mainly designed for living a life without cardiovascular diseases. When you take all the things that we learn from cardiovascular diseases into rheumatology, you find that there is a lot of relationship there. So this is perhaps because of the interplay between cardiovascular, inflammation, and rheumatic diseases. So all the inflammatory diseases can benefit from a healthy lifestyle. So instead of saying cardio healthy lifestyle, we can say joint healthy lifestyle. Okay, so that's one of the reasons why I think that rheumatologists should also be involved in preventive actions at higher levels, not only cardiologists, right? The same happened with COVID, right? We had to be there for all these exaggerated inflammatory reactions, right? So I think that rheumatologists need to be there. Something that is important to remark here is that we have over 200 diseases. Each one of them have different pathogenic pathways, they have different triggers, and they have different factors that can make the risk of developing the disease higher, right? So just think about some of them. Of course, the genetic diseases cannot be changed too much, but one of the abstracts I pointed out, the gene and diet interaction. This study was done in a very large cohort in the United States, the Nurse Health Study, and they found that people with a genetic risk score, which was based on all the genes that have been associated to developing gout. These people who had a high risk of developing gout were studied in relation to different diets. And they also studied people with low risk of developing gout with different types of diets. And they compare a typical, what is called DASH diet, which is very much like the Mediterranean diet. So it's rich in fruits and vegetables and low in salt. And compare it to a diet, what's called a Western diet, with lots of meats and processed foods. So what they found is that if you have a high risk of developing gout, the fact that you eat a Western diet, either if you are fat, you are obese, or you are not, you will develop gout with a higher probability. So if you have the genes, you can still do something to avoid developing the disease. And if you don't have the disease, if you don't have the risk, but you are consuming lots of meats and high processed foods, then you will develop gout, even though your risk to start with was not high. So this is something that supports the idea of having a healthy diet at all. So all the diseases in which we can do something to prevent, for instance, is osteoporosis. So we know that until the age of 29, you are developing your bone mass, right? And to develop your bone mass, you will need to do exercise, you will need to be exposed to sun, and you will need to have a diet rich in calcium and vitamin D products. So we can prevent osteoporosis in a later age if you are living a joint healthy life during your childhood. But talking about childhood, we have this abstract on the French cohort EPIC, in which they studied over 75,000 people in France, and they studied what was the exposure to smoking, either active or passive, and they found that there is a risk. So if you do not smoke yourself, but in your environment, your in your family or in your work or your friends smoke and the exposure reaches certain levels, then you have a higher risk to develop rheumatoid arthritis. So that's an important message. It's not only what you are getting into your lungs, but yourself voluntarily, but also involuntarily. So probably you know, or if you don't, I will remind you that rheumatoid arthritis already was known to be related to smoking, because actually the first organ in which the disease starts is actually the lung with the anti-citrulline peptide antibodies. So it is very important that we know that it's not only that smokers have a higher risk, but also passive smokers. So this is an important message from this Congress, right? And then finally, external pollution, right? So one can think about pollution and the association very clear with respiratory diseases, right? And also with allergic diseases. It's like we see the chemicals in the skin, and we see very clear that association. But should we worry about rheumatic diseases and pollution? Well, actually, we have more than one abstract on pollution in this Congress, and actually we have a session on challenges of planetary changes on pollution as well. And what we selected for you in this abstract, what they found is that people who have inflammatory diseases and are being visited regularly, when we compare periods in which the air pollution is high, as measured in the area where they live, when the pollution is high, then the response to biologics is lower. So this is something very, very new. We didn't know that there was so fast the association between pollution and an effect on disease and on inflammation. So pollution at some point might be interacted with inflammation. So this is just a part of the picture. It's not the risk of developing a disease, but the risk of not responding to medication. So probably we rheumatologists should also become at some point planetary activists, right? So yes, with this, I will stop here. I really want you to go through the program and see what is interesting for you. And you know, science, how this is little by little, different pieces of the puzzle to improve our lives.
Thank you very much, Loreto, and good luck with your next career as an activist. We are a bit short on time, but I give you one question which you can hopefully answer quickly. Can you elaborate what other things can we do to prevent RMDs besides the ones that you already mentioned?
Yes, of course. I think one of the most important ones would be exercise, right? I already said that exercise helps you prevent, during childhood, help you prevent osteoporosis at a later stage. But also exercise helps you prevent osteoarthritis. And if you do not run into high-level sports, which also have some sort of downside, of course, to joints, exercise will help you have a healthy joint, of course. So that's one of the things that we really need to care about, and how to build healthy cities in which you do not have to use the car for everything that you have to do. So just walking and cycling or things like that. Yeah.
Absolutely. Of course, there are many more aspects to these questions, but thank you for a short answer. So that now we can move to our final speaker for today. Thank you, Loreto. And I would now like to introduce you to Professor Angelo Ravelli. He is Professor of Pediatrics at the University of Genoa in Italy, and he is also the chair of the Pediatric Standing Committee of EULAR. And today he's going to talk about vaccinations in children with RMDs. So thank you very much, Angelo.
Okay, thank you very much, Carina, for your kind introduction. I wish also to thank the EULAR Standing Committee for including the pediatric perspective in this press conference. So my task today is to discuss and comment for you an abstract that is devoted to the issue of vaccination in rheumatic diseases in children. So let me start to highlight the importance of this topic for pediatric rheumatologists, because as you know, children are exposed to many vaccination procedures and the schedule is quite tight. So the issue of the risk of interactions between the vaccination and the disease state and also the treatment that is conducted is important, is extremely relevant for us. And we get, as pediatric rheumatologists, a number of phone calls or emails or WhatsApp from families asking us about what they should be doing with the treatment and with the disease in the relationship with the vaccination procedure. So there are indeed still a number of uncertainties regarding vaccination in children, in particular what is the risk of disease flare or disease exacerbation after vaccination procedure, what is the risk of reduction of efficacy of vaccines in children who are receiving immunosuppressive or biologic medications, and also there is it is still unclear whether these medications should be discontinued before and after vaccine, and what is the most correct approach to discontinuing specific particular medications. A few years ago, a task force was gathered within the EULAR, which has published the recommendation for vaccination in children. Now there is a new effort has just been started, which is aimed to revise, to update these recommendations for pediatric rheumatologists. And another demonstration of the importance of this issue is that PRESS, the Pediatric Rheumatology European Society, of which I'm currently the president, has created a new working party which is specifically devoted to vaccination. There is also another problem is the difference in the calendar of vaccination across countries, which should be addressed and try to be should try to make it a bit more homogeneous. Anyway, the published literature on vaccination in children with rheumatic diseases is quite reassuring so far, because no risk of flare after vaccination has been consistently observed. Vaccines have been shown to be efficacious, reasonably efficacious. There is the issue of COVID-19 vaccination, which is still open, because nowadays individuals who are younger than 16 years are not intended to be vaccinated yet. This should occur in the future, so we need to address this problem in the next month. So said that, the abstract published from this Russian group has explored the risk of disease flare mostly, and the safety of two vaccines against pneumococcal and Haemophilus influenza type B infections, which were given simultaneously to 430, so a sizable number of patients with juvenile idiopathic arthritis. They administer the vaccine, and then 3 weeks after the vaccine, they evaluated the disease state before the vaccine and 3 weeks after the vaccination, and they found that children who underwent this combined vaccination did not have any increase in the markers or in the clinical parameters of this activity, but they didn't have an increase in the risk of uveitis, ESR and CRP, so the acute phase reactants remained stable, and they found a minor increase in the concentration of calprotectin in 10% of the patients, but this finding has an unclear relevance. So overall, this study add to the reassuring finding published in the past regarding the potential risk or impact of vaccination on the disease exacerbation. Happy to answer questions.
Thank you very much, Angelo. Do we have any questions? Yes. Angelo, are there recommendations available for COVID-19 vaccinations in children with RMDs?
Yes, it's an important question. As I said, children younger than 16 years are not yet included in the vaccination procedures, because we have to wait the results of the trials that are ongoing in children and adolescents with various vaccines. Probably in the next few months, children will be started to be vaccinated against COVID-19. What we have, for instance, what we have done within PRESS, but also in Italy, within the Italian Pediatric Rheumatology Study Group, was to recommend to vaccine the family, household, or caregivers of children with rheumatic disease, particularly of fragile children who have the more severe forms such as lupus and systemic vasculitis, or are under treatment with major immunosuppressants or high doses of steroids. So the people who live together with children in the same house should be vaccinated, waiting for the start, as I said, of vaccination procedures in younger individuals.
And then we have one more question for you. What is the policy about temporary treatment discontinuation in children who receive vaccination with live attenuated agents?
Yeah, this is another important question, because I should say that there are not established and widely agreed rules. Now, it is usually agreed upon that children who receive vaccination with non-live agents, with non-live materials, let's say, might not need to discontinue the medication before or after the vaccine. Whereas children who receive live vaccination with live attenuated viruses, for instance, they should usually they are discontinued from medication between 1 week to 1 month before the vaccination, and then we restart the therapy 1 or 2, 3 weeks after vaccination. But this is really widely variable across centers and across pediatric rheumatology. So there is the need to find a consensus and agreement about the policy regarding this approach across pediatricians. So there is a lot of work to do in the field of vaccinations in pediatric rheumatology.
Absolutely. Very good. I think we have reached the end of our press conference. If there are no other questions from members of the press, please remember, for any additional questions, you can always reach out to us, to our press office, press@eular.org, and then we will happily respond to your questions. Yes, can I invite all of our speakers to switch on the cameras again? I would like to thank you for your participation, for taking the time to talk about these exciting studies and projects and initiatives. And all of us, we are very much looking forward to the Congress and to hearing more about these new initiatives. Thank you very much.
Thank you. Bye-bye. See you soon.
See you soon. See you on the Congress.
Thank you. Bye.
Thank you.
Bye.
Goodbye.
Bye.